Dr. Jack Cuzick. He's the John Snow Professor of Epidemiology at Wolfson Institute of Preventive Medicine at Queen Mary, University of London. Dr. Cuzick.
Thank you, Carlos. I'm delighted to speak about our IBIS-I prevention trial, which began in 1992, and we now have very long-term follow-ups. I'm pleased to say my co-chairman, Professor Forbes from Australia, Professor Howell from Manchester, are also here if you want to ask some questions afterwards, and Dr. Sestak, who did a lot of the data analysis. I think we have to recognize that breast cancer is truly the epidemic of our century. The rates are dramatically higher than any other cancer in women at 1.6 million cases per year in the world, and you can see these rates are dramatically rising. So treatment is really not enough. We have to really get the incidence of this disease down. The IBIS-I study, as I said, began in 1992, randomized just over 7,000 women for either 5 years of tamoxifen or a matching placebo. It's been reported previously, as have a number of other trials with tamoxifen, showing clear benefits of about 30 to 35% in the first 10 years of follow-up. What's important about this particular analysis is we now have very long-term follow-up. The median follow-up is 16 years. Many patients have had almost 20 years of follow-up, with the longest follow-up now 22 years. The women were about age 50 when they entered this trial on average. Only about half were postmenopausal, half premenopausal. One of the important features of this trial is that we did allow hormone replacement therapy use during the trial, and about half of the women actually used that, and that turns out to be important. And about a third of the women had had a hysterectomy before entering into this trial. So with 16-year follow-up, that means the median age of these women is now about 66 years. So there's a substantial amount of follow-up still to be done. After 10 years of follow-up, these are the separations. We showed a clear separation in the first 10 years. On the placebo arm, 6.3% of the women actually got breast cancer, compared to 4.6% with tamoxifen. A hazard ratio of 0.72, or almost a 30% reduction. The number needed to treat to prevent one breast cancer in the first 10 years was 59. So that's very much in keeping with what we've seen previously and reported in the previous overview of the prevention trials earlier this year. What's new is that with an additional 10 years of follow-up, we now have substantially larger differences. The hazard ratio remains around 0.7, or about a 30% reduction overall. But the differences between the two arms is now substantially larger. 12.3% of the women in the placebo arm developed breast cancer, compared to 6.8 in the tamoxifen arm. That works out as a number needed to treat to prevent one breast cancer in the first 20 years of 22, which is very favorable compared to any preventative treatment for heart disease or anything else in these kinds of general populations. So if you put these two things together, you see this clear benefit both in the first 10 years, and the graph on the right shows the benefits after, only in patients that had not had breast cancer in the first 10 years. And you can see that if anything, the separations are slightly larger in the second 5 years than the first 5 years, and continuing to separate, which bodes well for the prospects that the prevention may even be longer than 20 years, potentially a lifetime. In terms of subgroups, this is the overall effect on top. Ductal carcinoma in situ had a large effect. Invasive cancer, similar to the overall effect. That was all estrogen receptor positive cancer, as we suspected. Estrogen receptor negative cancer, there was no impact over those first 10 years. And if you look at what happened with another 10 years, the only things that really changed is that we didn't see a continuing impact on ductal carcinoma in situ, a kind of precursor lesion, which will become cancer if not treated. And we did see bigger effects on ER-positive cancers, but some concern about the fact that estrogen receptor negative cancers were becoming more common in the longer follow-up. The effects were pretty similar by age. Hormone replacement therapy turned out to be important. We found the effect was really only clearly demonstrated in women who did not use hormone replacement therapy during the treatment period. This was seen both in the first 5 years and subsequently afterwards. and that was a significant difference, that women who did not use hormone replacement therapy had a much bigger benefit from tamoxifen than those that did. In terms of other cancers, there was an increase in other cancers. Endometrial cancer was anticipated. Those cancers occurred really only in the active treatment period. We had 9 more cases altogether. A somewhat unexpected event is that, in fact, we did see a large increase in non-melanoma skin cancers, really very low risk for mortality cancers, and that's where most of the differences were. So it raises the question as to whether there's any mechanism that tamoxifen might be causing these cancers, something important but we don't fully understand. Colorectal cancer, which was thought in some previous adjuvant studies to be related to tamoxifen, was actually reduced in this study, so no evidence for that at all. In terms of deaths, in our 8-year report, we saw an increase of deaths. It's no larger. In fact, it's a little bit smaller now. There's been no impact on breast cancer mortality thus far, 31 in the tamoxifen arm, 26 in the placebo arm, so really no difference, no significant difference. As you can see, the number of deaths is really quite small from breast cancer. It's 57 compared to over 600 cases. So less than 10% of the women who had breast cancer have died of it, and it's actually probably too early to make any real pronouncements, favorable or unfavorable, about deaths from breast cancer. That's going to actually take another 10 years of follow-up, and that's an indication of how long prevention studies take. The cases of endometrial cancer did translate into mortality. We hadn't seen that in our last analysis, but there have been 5 deaths from endometrial cancer. Clearly is an important side effect of tamoxifen. Really not much else. The other cancers, there's virtually no difference, a small increase of 5, but there's no particular cancer, and that's likely to be a chance finding. No impact on other causes of death. So in summary, after 20 years of follow-up, there's a clear benefit in terms of preventing breast cancer. This is very important. It's the key message that the effect continues. For all breast cancers, we reduced it from 12.3% to 7.8%. The number needed to treat to prevent 1 breast cancer is 22. And if we focus on just invasive ER-positive breast cancers, the number needed to treat is 29. So thank you for your attention.
Thank you, Dr. Cuzick. I'll start with the first question. This interest in non-melanoma skin cancers is interesting to me. I guess these are basal cell and squamous cancers?
They're basal and squamous.
Are they known to have ER estrogen receptors?
There is some evidence that skin receptors are found in the skin. We haven't actually looked at these specific cancers. I think it's an important question. We'll be trying to get the blocks to do that.
All right, then questions from the room. Neil, you got the first one after the mic.
Hi, Neil Osterwell from Medscape. I just have a general question about getting women who are otherwise healthy to use tamoxifen. There was a piece in JNCI recently saying that the percentage of women who could benefit from tamoxifen but don't take it is fairly large.
It's very large, yes.
Yeah.
Well, it's a major issue. I think the cardiologists have been very effective in terms of identifying things like high blood pressure and high cholesterol as diseases which need treatment. We have to find a way, I think, to make it very clear that women at high risk of breast cancer should be offered treatment. They should be offered that much more often. I think much of the problem is still in the education and medical profession. There is still a misunderstanding about the side effects of tamoxifen. Some women do get them, but that's no reason to not give it a try. If you have side effects, you can always stop and they'll disappear. The benefits on breast cancer and the risk of breast cancer will continue.
May I ask some of the other panelists if it's true in your practices? Same thing?
Yes.
Okay, thank you.
Bruce?
Bruce Jansen from Oncology Report.
Hi.
Can you think of another drug for primary prevention of anything that you give for 5 years and has such a long downstream, potentially lifetime benefit?
No, I don't. I mean, we're actually looking at that for aspirin. There is some evidence that aspirin, which is a very important preventive, probably for the general population, that if taken for at least 5 years and probably 10 years may produce very long benefits for cancer. So that's one potential. But this is the only clear case in which preventative activity will actually produce such a long benefit.
Marisa Weiss, breastcancer.org. What is the adherence to the 5-year course of tamoxifen in a study population? And my second question is, did you see more DVTs and clotting disorders in the women who are taking both tamoxifen and hormone replacement therapy?
The 5-year compliance was about 70%, and it was very similar between the placebo arm and the active treatment arm. There was just a 4% difference in those two. So much of the reasons for non-compliance were not drug-related. They were often side effects, but they turned out not to be drug-related. In terms of DVTs, yes, we do see the increase that will be reported in the full paper, and we could not see a clear difference associated with combined with HRT at this stage.
Elaine Shatner, Forbes contributor. It's impressive data. I'm concerned and surprised by the ER negative tumors you saw over time. Can you give us some numbers on that? How many you saw? And do you think there's a causative role potentially in the tamoxifen, somehow factoring in?
Yeah, I think the numbers are actually in the paper. I don't want to try to recite them, but they're much smaller than the ER-positive cancers. And the paper is available. It's actually published online today in Lancet Oncology, so you can all get copies of it.
Well, I mean, another way of asking that question is how many ER-negative cancers, which in general are more invasive or aggressive, might be caused by tamoxifen?
I don't think that any of them are actually caused by tamoxifen. My explanation, and this is hypothetical still, is that there are some cancers that would appear as ER-positive cancers if untreated. Tamoxifen will hold them in bay for some years, but when they escape tamoxifen control, they escape as ER-negative tumors. That's been seen in the adjuvant treatment setting. I think is very likely to be the case here. So I don't think we're seeing tamoxifen causing any, but we are seeing an increase due to the fact that cancers that would have arisen as ER-positive cancers arise later as ER-negative cancers. It's not a causal factor.
I'm just wondering about, Suzanne Rose from Cancer Discovery. I am just wondering about the 5-year term of taking tamoxifen. How was that determined, and could it possibly be shorter to encourage greater compliance, or does it actually perhaps need to be even longer?
It's a very good question. 5 years was chosen because at the time it was the conventional treatment for adjuvant, for women with breast cancer. Since then, there's been evidence that in fact 10 years is a little bit better than 5 years for treatment of women with breast cancer. We saw the same benefit during the follow-up period as we did during the active treatment, which suggests to me that continued treatment is not likely to have very much additional benefit. The question of whether you can treat less long is an important one and a challenging one. I think it would be a challenging trial to actually compare 2 versus 5 in this setting. So it's an important question, and I'm not sure we'll ever give a clear answer on that.
All right, thank you. Dr. Artiaga, we're ready for the next speaker.